Welcome to the Impact Medicom podcast. I'm your host, Anna Christofides. We are currently at the American Society of Hematology meeting in New Orleans, and today's episode focuses on the final analysis of the ALPINE randomized phase 3 trial comparing Zanubrutinib to Ibrutinib in relapse refractory CLL. This study was chosen as a late-breaking abstract at ASH and presented by Dr. Jennifer Brown. Dr. Brown is the director for the CLL Center of the Division of Hematologic Malignancies at Dana-Farber Cancer Institute, and also professor of medicine in the field of hematologic oncology at Harvard Medical School in Boston, Massachusetts. We're excited to discuss the results of the ALPINE study with her in this episode. Hope you enjoy it. So welcome, Dr. Brown, and thanks so much for joining us at the American Society of Hematology meeting in New Orleans. We're excited to discuss with you today your presentation of the final analysis of the ALPINE trial of Zanubrutinib versus Ibrutinib for the treatment of relapsed refractory CLL, which was selected as a late-breaking abstract. So congratulations and welcome.
Thank you.
So the first question I had for you was, what was the reason for the development of the second-generation BTK inhibitors following the success of first-generation molecules such as Ibrutinib?
Well, Ibrutinib was highly effective. I think there were clear areas for improvement. There's certainly a lot of toxicities. We know Ibrutinib is not very specific for BTK. And there are, for example, the skin toxicity of Ibrutinib is almost certainly an off-target toxicity. There's significant cardiac toxicity, bleeding toxicity. And so if a more specific drug could overcome that, that would be very good. It's very good. And then there's also the possibility for enhancing the extent and depth of BTK occupancy. The data with Ibrutinib on BTK occupancy are not that extensive, but they do suggest that there's some lag, some downward lag in the trough occupancy values before the next dose over the 24-hour dosing interval. And so it may be that enhancing that and maintaining the occupancy throughout the dosing interval would improve the effectiveness as well.
That makes sense. And so what are some of the key concerns? I mean, so you've mentioned a couple of the safety concerns with Ibrutinib. How are these likely to be improved with the use of Zanubrutinib?
So that's interesting. We don't understand the cause of most of them, which means it can be challenging to know for sure whether any given particular toxicity would be improved, right? So I think we're most interested in the cardiac toxicity being improved. And we don't have a lot of data on the cause of that, although there is one nice paper, a preclinical paper that suggested that targeting CSK, as the enzyme CSK, is the cause of atrial fibrillation anyway. And Ibrutinib inhibits CSK, whereas Zanubrutinib much less so. So that's a plus in that regard. There are other assorted cardiac side effects that we don't know the cause of. For example, there's sudden death associated with Ibrutinib, there's hypertension. And we don't really know what the target enzyme is for those. So we don't necessarily know for sure whether they'd be improved by other drugs. The bleeding, I think, is at least partially due to BTK inhibition. So that is a class effect to some degree. Inhibition of TEC probably also contributes. So there could be some variability there based on whether the drug inhibits TEC. The skin toxicity is probably EGFR. And so all the newer drugs do not inhibit EGFR, and we do in fact see much, much less skin toxicity with them. And similarly with the diarrhea of Ibrutinib.
Great. Thank you so much for that really descriptive answer. That's very helpful. Thank you. So I'm just wondering if you could describe the design of the ALPINE trial and what was the reason for the selection of the primary outcome of overall response rate?
Right. Well, so it's a randomized phase 3 trial. It was open label, and it was really open to an all-comer population of relapsed patients as long as they had not previously had a covalent BTK inhibitor. So it ended up enrolling patients with one prior therapy, which was generally chemoimmunotherapy. And the randomization was stratified by a number of factors, the most important of which is probably 17p, p53 deletion, which is our highest risk factor. In terms of the primary endpoint, I think the overall response rate was really chosen to try and get an early readout. Zanubrutinib was perhaps a little bit behind compared to Acalabrutinib, for example. And so there was an interest in trying to generate data quickly.
And so in terms of progression-free survival itself, so how was this compared between groups, given that it wasn't the primary endpoint? And how can superiority testing be justified in this case?
Right. Well, so the statistical plan clearly saved alpha for progression-free survival. And so this was a planned analysis with appropriate power and planned for this time point after 206 events had occurred. So that's how, basically. Yeah, it was a key secondary endpoint.
Yeah, no, that makes sense too. And can you talk a little bit about the progression-free survival results in both the all-comers and in the deletion 17p population?
Right. So the progression-free survival results now with the median follow-up of 29 months show a 12% improvement with Zanubrutinib compared to Ibrutinib. 79% of the overall population was progression-free. So that's really pretty significant at 2.5 years, 10% difference. But, I think what is even more extremely notable is that there's a 22% difference in our highest risk subgroup, the 17p group. So that really suggests that there is a definite efficacy benefit, I think. We see that anyway when we look in the sub-analysis of the entire population for PFS, because about half of the difference is patients coming off for adverse events and half of it is patients progressing. So there is a significant component of it that's people progressing while taking drug. But then the fact that that is even more evident in the high-risk patients, I think really underscores that there's an efficacy benefit.
That makes sense. So in your mind, that you would see that as a clinically meaningful difference in both populations.
Yes.
Yes. Yeah. Okay, great. Is there a sort of threshold? I'm just curious about what number you would put at that, where you would say, okay, this is clinically meaningful.
Yeah, that's interesting. 5% is a little borderline, but I think most people would say 10% is significant.
Great. Yeah, thanks so much. Just talk a little bit about the overall response rate results for the updated analysis, if you can.
Well, so there's about a 10% improvement in overall response rate as well. For Zanu, it was 86% versus 76% for Ibrutinib. And that's complete response plus partial response. It does not include partial response with lymphocytosis, and that was really because of regulatory mandate. There are still pretty low rates of complete responses in both arms, which is totally expected. We don't see many complete responses at all with single-agent BTK inhibitors in the relapse setting.
Yeah, that makes sense. And so can you talk a little bit about the difference that you saw in discontinuation rates? I know you hinted at that. And then just your, understanding or interpretation of how that might be related to the difference in efficacy.
Right. Well, so covalent BTK inhibitors generally have to be given continuously to maintain response. That's the plan, and that's how they're done. So that means that people who come off or whose disease progresses, they could have actual disease progression while taking the drug. Or alternatively, they could come off for an adverse event and then have subsequent disease progression. So how do we tell the difference? Well, so in this study, as I mentioned earlier, about half the patients did progress while taking the drug. And then about the other half came off for an adverse event with subsequent progression. And in fact, rates of treatment discontinuation for adverse events, as well as rates of interruptions and dose reductions were all lower with Zanubrutinib. But we also did a sensitivity analysis in which progressions that occurred within 6 weeks of a 1-week hold of the drug were not considered as progressions. And the difference in progression-free survival was still significant.
Oh, that's very interesting. Yeah. Okay. And so just looking now at the safety data, can you discuss the difference in adverse events between the two groups?
So it's the cardiac events that really stand out in my mind. There were, well, first of all, atrial fibrillation was only about 5% with Zanubrutinib versus 13% with Ibrutinib. So that's a quite significant difference. And then there were also significantly fewer cardiac serious adverse events, fewer events leading to discontinuation that were cardiac, only 1 in Zanubrutinib versus 14 with Ibrutinib. And there were also 6 cardiac deaths on Ibrutinib, whereas there were 0 with Zanubrutinib. And that really stands out to me as a really big difference. Many of the other side effects, neutropenia, infection, were about the same. Diarrhea was less with Zanubrutinib as well.
Huh, interesting. Okay, and so those were the most notable differences in your mind. Were there any that were higher with Zanubrutinib, or?
Well, neutropenia was very slightly, but it was just 2 or 3% out of 20%. So it's not really that different. Hypertension, people are pretty interested in hypertension as well. And That was pretty similar. I think it was a couple points higher with Zanu compared to Ibrutinib. But it's also a late side effect. And so I think it's something that we're still going to want to see in longer follow-up, because we do know Ibrutinib tends to have continuously increasing rates of hypertension over time. In the ALPINE trial, which was a different head-to-head trial of Zanubrutinib versus Ibrutinib in Waldenstrom's macroglobulinemia, there was about half the rate of hypertension with Zanu compared to Ibrutinib at 40 months, although they had also seen it earlier too. So, I think it's not clear why the hypertension results are not different compared to the other cardiac results, but longer follow-up will be interesting.
Yeah, that makes sense. Interesting. And so what do you make of these safety results in terms of applying them to clinical practice, in terms of monitoring and patient management and so on?
I think that I feel comfortable giving Zanubrutinib to even patients with quite significant cardiac comorbidities. I've already been doing it, actually, and not really had a problem. But patients to whom I would never have given Ibrutinib, even if they had basically no other options. So I think that that's one key point. And there was an update to the Ibrutinib product label recently talking about sort of screening patients ahead of time in terms of their cardiac risk, considering getting EKG or echo at the physician's discretion. I do usually get an EKG on anybody for a BTK inhibitor, but I think you need to be much less worried about it with Zanubrutinib than with Ibrutinib.
That makes sense. And is there anything that you would comment on, even though it's not a direct comparison to acalabrutinib?
I've had similar experiences with acalabrutinib in terms of its usability in patients with significant cardiac comorbidities. We had access to it a lot longer than Zanubrutinib, so I've had opportunity to get that experience. Obviously we don't have a head-to-head comparison of acalabrutinib and Zanubrutinib, and probably won't get one, I suspect. So,
yeah, for sure. So based on the efficacy and safety data from this study and, data from other trials, would you choose Zanubrutinib over Ibrutinib? And also just talk about, could you transfer this to the first line setting?
Right. So that's interesting. I think unequivocally in this relapse setting, you would choose Zanubrutinib because this is the patient population in which has been shown to have a better progression-free survival than Ibrutinib, right? And the question isn't really so much versus Ibrutinib, it's more versus acalabrutinib, right? Where we don't have that head-to-head data. I think I'm willing to translate it to the frontline setting, but it becomes a little bit more ambiguous because trials are so different, right? For example, we have data in the frontline setting with acalabrutinib and obinutuzumab with really phenomenal 5-year progression-free survival rates of 84%. So if a patient's willing to have obinutuzumab, and there's the possibility that might, say, speed up response, maybe I'd still choose acala for that patient. But if they're just going to have a single agent, I'd probably choose Zanu because that's been compared head to head. My default would probably tend more towards Zanu, but like I said, that data with acala is quite compelling as well. So, we'll just have to see how these data sets mature over time. Also, if we can start to get institutional experience or real world experience of the different drugs, that would probably help too.
Yeah, that makes sense. Yeah, I guess it's all moving so fast, so it's which is a good thing too. But so is there anything else that you wanted to add in regards to this trial or anything else?
I will say also, I think that the data for 17p deletion versus Ibrutinib in this trial, together with the fact that we have the largest prospective cohort of 17p deletion frontline in Sequoia, even though it's not as mature as some of the other data sets yet, I think that is also giving Zanubrutinib a leg up for the 17p population.
Great. Yeah, that makes sense. Yeah. Well, I thank you so much, and I hope you enjoy ASH, and I really appreciate you joining us today. Thank you, Dr. Brown.
My pleasure. Thanks.